Assalamu alaikum wa rahmatullahi wa barakatuh. In this recording, we are going to continue our preparation for clinical MRCPCH. In the previous recording, we discussed neurological examination for CNS station, and we spoke about motor examination, sensory examination, and coordination, and we skipped cranial nerves, and also we skipped the approach for floppy infant. Floppy infant, like a case of spinal muscle atrophy, it's not common in exam, but we should know the approach of floppy infant. So floppy infant, it's like the same our approach, and you add to it the general examination. So from the general examination, starting with the inspection, with the screening look, you have to comment about the specific features of SMA, floppy, bed-like chest, and anxious look, all these common findings in SMA. And you add in your motor examination the 180 degrees, which are the motor part of development in infant. So you will check the neck or head support, okay? You will check how's the baby sitting with support or without support. You will try to make him stand up and not how's the position of the legs, and you will put him on ventral suspension, okay, and see what posture he's taking. And finally you put him on the prone position and check how's he doing. Is he able to raise his head from the ground? So this is what usually we do for motor assessment of infant, okay, or below 1 year, and also check if he's turning from one side to another. So this is the only thing you are going to add, and add to this the primitive reflexes as well, the grasp, Moore reflex, rooting reflex, all the neonatal reflexes. This is what usually we do for a floppy infant. So that's why I didn't deepen in the details in this station. It is not common, and also the only addition is a few things, and you can pick it up once you log in, and you can notice if this is a floppy or not. Now, the most important remaining part we didn't speak about is cranial nerve examination. And as I mentioned earlier, that cranial nerve, 50% of it is, even more than 50%, is eye examination. So if we are talking about cranial nerves, you have to know that we are mainly talking about eye examination, which can be a single station. So let's now just remember and remind each other what are the cranial nerves. Okay, the first cranial nerve is the olfactory nerve, which is responsible for smelling. Don't expect in your exam that you are going to be asked to check or to examine olfactory nerve, okay? Because something subjective, and you have to bring a lot of things with different smells, and it's not appropriate in the exam settings to even try. But you should at least mention this, that usually you should check for olfactory, but I'm going to skip to the optic nerve. Optic nerve, okay, so there are some tests I have to do to confirm that I'm examining the optic nerve and I'm commenting on it. So optic nerve is the second cranial nerve, okay, and it's the one responsible for perception of vision, okay. So the first examination, once I log in inside the room, I have first to comment about the both eyes, okay, and both eyes means the eyebrow, okay, lids, conjunctiva, okay, pupils. So all these things I have to comment for inspection, okay. If there is obvious proptosis, okay, I have to comment. If there is enophthalmos, I have to comment. If I cannot conjunctival injection, okay, any obvious malalignment, I have to comment as well. So this is by inspection. This is the first step. And before that, if the patient is wearing glasses, I have to say that he's wearing glasses. And if I cannot see glasses, even in the environment, I have to ask. Sometimes they are keeping glasses in the pocket, or maybe with the father, so they want to check if you ask for it or not. Okay, so first I ask for glasses. Let's say that he's wearing glasses, or when I asked, they give glasses to me. I have to examine the glasses first to know is it for near vision or far vision. And please don't ask about the glasses if it's for near vision or far vision, because you are expected to know. How can I know? Okay, as we know, the concave glasses are for near vision and the convex glasses are for far vision. What else I can do? I can take the glasses like this. This is the glasses, okay, and I can put like I want to try to read with it. I can see the letters, okay, outside the field of the glasses. How is it? And after I use glasses to see, if it magnifies the letters, okay, so that means it's for the far vision. If it like decreased the volume of the letters, okay, so it's for the near vision, okay. And how can I comment on astigmatism? Okay, if I'm trying to use the glasses in any straight sharp edge, okay, and see how's the outline of that edge, like this, okay. So if I notice any deviation for the line, that means there's a degree of astigmatism. I'm not expected to know what's the degree, but any malalignment of the line, okay, in deviation, that will give us clue that there is astigmatism, okay. So I have to identify is it for far vision or field vision or near vision, and I have to comment over it. Okay, so what's next? Then I have to check visual acuity myself. So usually you are going to assess a cooperative child who's age of around 5-6 years old, if you are going to be asked for cranial nerve examination, because it's mainly subjective testing, okay. So they have to ensure that you are provided with a very good cooperative candidate. So you have to check first if he's able to read something close, like if you have a notebook or any drawings or any something can be read, or any something can be identified, like a picture, image, anything, you have to show to the baby in a very near vision, like distance of 1 meter or less, and ask him to identify, okay, what's this, or can you read it, if for sure if he's able to read, okay, or can you describe, or whatever. So how can I do that? I have to use each eye individually. So don't commit this mistake, like you ask him if you are able to read with both eyes, because maybe he's using the other eye and there's diseased eye. So you have to try covering one eye and ask him if he's able to read like this. And you have to repeat the same with the other eye and the same. If he managed to read or know or identify the object or read the letter from the near vision, you have to try from a distance which is exceeding 6 meters. So you try like less than 1 meter, and then you go to the the corner of the room, a distant part, and ask him to identify the same objects from that distance. Okay, if he's able to do that, so that ensures that he have a good near vision and far vision. Okay, let's say he's not able to identify that object from that distance, so you come gradually, slowly, and approaching him. Okay, so once he identify or recognize that object, okay, so you identify that he's able to see or recognize the objects from a distance of 3 meters, for example. Okay, in like later age, like age of 8-9 years, we can use Snellen charts, okay, with the well-known E letter, okay, or C letter, and identify where's the object, the opening, and then we can give him a grade for his visual acuity. Okay, is it 6/6 or more than this, like 12/6 or whatever. So based on that, okay, we know that there's some sort of whether he's able to see or there's some diminution. Let's assume that he was not able from the beginning to identify the near object vision. So I have to try what's next. I have to try hand counting. So how many fingers? And then he will say, okay. And I try also from some distance if he's able to see from near vision. So I try to show to check if he's able to see also from some distance. Okay, so counting fingers, okay, and I use each eye separately, as I said, and then after hand counting there is hand waving. Okay, if he's able to count, I will check if he is able to recognize hand waving, and again for each eye separately. Let's say that he's not able to check or I mean to recognize the hand waving, then I proceed to the last step, is the perception of light. Okay, so I approximate, while I'm covering the other eye, approximate the torch to his eye and check if he's able to notice that there's light or flashing or anything, flashing of lights, then he's able to see that light or perceive that light. Okay, so this is what we do usually for visual acuity, the first test in optic nerve. What's the second test in optic nerve? We have confrontation test we use to check for visual field defects. You have to train yourself so as not to be confused in the exam and to know what test you are going to do and the sequences of the test. Okay, so how can we apply confrontation test? You have to have a distance of around 1 meter and you sit in front of the patient, okay, in 1 meter distance, and both of you are looking to each other, eyes are looking at each other focusing your eyes on his eyes, okay, and then you will cover your left eye with your left hand and ask him to cover his right eye with his right hand. Is that clear? So both of you having this field of vision, okay, like not covered, and the other one is covered, okay, and then you will show your hand like this, wiggling, okay, from far to close to the center, and you will ask him without moving his neck towards your waving hand, okay, to tell when he is able to see or to recognize the wiggling of your hand. So you do like this and tell me once you see. If you are able to see at the same time, so there is no problem, as you have waving your hands just in the center between both of you at the same distance, and see. So like this, and then like this, okay. Then you want to check the same eye, okay, but the other side, so like this, okay. So you check one eye, you want to check your other eye, okay, you cover like this, and you do like this, you do like this, okay. So, and then you use the other hand, and you do like this, okay, and do like this. And if there's any visual field defect, you will do eye, and you just identify what quarter he is not able to see. So it's 4 quarters, and for each quarter, as we just demonstrated, you will be able to detect where's the defective quarter. Okay, so just try to train yourself with your friends, your other candidate you are practicing with, because it's confusing, so you should be able to do it fluently in exam. So this is for the confrontation test. What else remaining for optic nerve? Okay, so we have consensual and light reflex. Light reflex, as we can know, that you are approximating a torch, okay, to one eye, you are covering the other eye, okay, and see if there's a pupil constriction secondary to perception of light. So the afferent is optic, and the efferent is the oculomotor by supplying the ciliary muscles. Okay, so this is a very good test. Then you check for consensual if there is no problem consensual perception of light. So you check while you are covering like this, you expose this to light, and you check the other one, okay, if there is also pupil constriction secondary to reception of light or not. Okay, so this is the third test we are using for optic nerve. Okay, and then we have accommodation. So you are approximating object or the torch itself to the nose and see if there is convergence or not. Okay, so this is also another test we are doing. So this is the fourth test. Okay, these are the tests we are doing for optic nerve. Then we will proceed to the nerves, motor nerves, or nerves used for movement, eye movements, to check in case of cranial nerves. So we have oculomotor, which is the third nerve, we have trochlear, which is the fourth, and we have abducent, which is the sixth nerve. 3 nerves are responsible for the eye movement. So eye movements, I have to check first if there is any obvious malalignment, okay? Because if there's any obvious malalignment which is persistent, okay, and I notice one eye is not moving at all, so it can be something which is called paralytic squint, or we can say non-concomitant squint, or we have non-paralytic or concomitant squint. Means there's one eye which is defective in vision or having some weak muscles, or mainly it's diminished visual acuity rather than weak muscles, and it's like the eye trying to keep the same like gaze of eye movements, so both are moving like this, but sometimes there's certain angulation between both eyes, so it will be moving like this. Okay, so this is what we can say as concomitant or non-paralytic squint. Okay, and how can we differentiate? Okay, we have to do the H-shape eye movement, so checking, so we are approximating certain object and ask him to follow, and then we go in this order, okay, like I'm doing H shape, and see how our eyes are following. If there is any abnormal movement, okay, I have to check, and I have to know the certain abnormality in each nerve palsy. So for example, I will have clues like oculomotor, I will have ptosis, and I know from the beginning that during light reflex the pupil of constriction was not there, so there was pupillar dilatation, and these are clues which will give me also idea, and there's some inner deviation, okay, up, so oculomotor, I have to be aware about the certain abnormalities in eye movements secondary to nerve injury. So this is for the paralytic part, and the same for abducing, as we know that abducing is causing abduction of the eye, so if there is any paralytic on this side, there will be no abduction, and same as the trochlear, as we know there will be also abnormality of deviation. So these are like what I'm expecting in case of checking for any nerve injury in case of paralytic squint. Then we do, if there is no nerve injury, so we will do what's called as covering test. We use unilateral covering test. I will see now that there is one eye is deviating and the other eye is focusing. So what I do usually, that I cover the first the deviating eye. Okay, so sorry, I cover the focusing eye. I cover the focusing eye. Then I notice that the deviating eye is taking the job and focusing instead of the healthy eye or the unaffected eye. Okay, so when I remove it back, I find that again that squinting eye is relaxing or deviating as it was before. So it's because that eye is weak, so for our our brains are trying to avoid diplopia, like double vision, so it tries to ignore the image coming from the deviating eye and use the other eye. Okay, that's why with the time this eye becomes more weak and weak because of that. So when I'm covering the healthy eye, I'm forcing that weak eye to see. Okay, so that's what happens when I use covering test. Okay, so sometimes when the baby or the patient does not look that he's having a problem with a squint at all, we do alternating cover test to check if there is any degree of latent squint. What's meant by latent squint means that there is like a hidden or not obvious degree of squint. Okay, so there is one weak lazy eye which tends to rest once you are not using. Okay, like what? Those who are having some degree of decreased visual acuity. So when I'm doing covering and like alternating covering, this one and this one and this one and this one, I notice that one eye, while I'm looking from side, once I cover, it starts to rest. Okay, so this is very common when what's called as latent squint. Okay, but if the patient is having obvious squint from the beginning, so that's why it's called manifest squint. Okay, so I have to differentiate. If I found that baby does not have any abnormality with his eyes, so I have to do rapid alternating test. So far it's clear, I hope so. So what's remaining in the eye examination, what's remaining is what usually we do for nystagmus. Okay, so I will go horizontally and I go vertically, okay, and ask him to follow and see if there is any like oscillation of both pupils, which is common in some diseases like cerebellar injury or appendicitis or any part of or sometimes effect of some drugs. So I have to comment if there is any nystagmus as well. Okay, so that's all for eye examination and cranial nerve examination. So we skipped trigeminal, which is the fifth cranial nerve. Trigeminal has 3 divisions. Okay, the first division is called ophthalmic. The second division is called maxillary, and the third division is mandibular. Mandibular has also motor part, so it has sensory part and motor part. For ophthalmic, okay, so it's sensory, so I can use cotton tip and ask him to close his eyes and say and comment once I touch his that I touched or not. So this is for sensation, and the same in the cheek, okay, to check for sensation, and here also in the chin to check for sensation, and I do both sides. This is for sensation, it's easy. And for the mandibular nerve motor part, we have to check if first I palpate for masseters, okay, and ask him to do forcible closing of his mouth and tense his masseters, and I feel while he's tensing if there's any degree of wasting or not. Okay, I ask him to do this movement, okay, by trapezoid muscles, and check if there is also any obvious deviation, like mandibular nerve injury. There will be deviation to that healthy side, so because trapezoids are applying traction over that side, so that means the other part is not healthy. Okay, and to check both, this is mainly for the lower motor neuron. I ask him to open against resistance, okay, and I ask him to close while I'm trying to open, okay, and finally we do shin taping to check the reflex, which gives us idea about the level, and if I tap like this with the hammer and some closure of that mouth happen, so that indicates there's positive reflex. Okay, so these are the tests we usually do for the trigeminal nerve. So after that there will be the 7th nerve, which is the facial. Okay, it's very important to know about the facial as well. Facial by inspection, as all of us know, you will comment over the wrinkling. Okay, so if there is any facial nerve injury, there will be absence of wrinkles here, that eye, okay, will not sound like mildly shut, it's not fully shut down, and also the nasolabial fold, okay, it will be absent in the area of paralysis, okay, and we check angle deviation of the mouth as well, so there will be absent of deviation to the healthy side, okay. So these are all by inspection, okay. So what I'm going to do next, first for the forehead, okay, I ask him to do like this and see the wrinkles, okay. Then I ask him to close his eyes like this and don't allow me to open them, and check if there is any good like power to close or not, if I'm able to force him to open his eyes or not, okay. Then what else? I ask him to blow, okay, or whistle, so, and see if there's, so he will be, if there's, so he will be able to use this cheek, but this cheek he will struggle to blow with, okay, or whistle, he will not be able. Ask him to smile if he's nervous, okay, so angle deviation, so there's a problem, and as we know, deviation to the healthy side. So these are important parts for facial. We have sensory part of facial, the tip of the tongue, and usually we just tell and we don't do. This is for the facial. So after that, the eighth nerve is the glossopharyngeal, the vestibulocochlear, sorry. So vestibulocochlear, okay, usually we examine the hearing of the patient by using tuning fork, okay, 512 hertz, and in exam, to be frank, usually we don't do, but you should be familiar with what's called Weber test, okay, using the fork, and also Rini test, okay, but we can, you have to know at the age of 6 months to 18 months we do distraction test, so while father is involved with the kid speaking or just playing with him, you come from behind, not allow him to see you, and you just release a sound or anything and check his response if he's getting to be going to be distracted or not. And sometimes you whisper, okay, in like age above that age, like 2 or 3 years, you whisper while you are sitting just away from his field of vision, like 1 meter away from his ear, and you whisper with a certain word without allowing him to see your lips, and he tells you what is that word, okay. So, and finally, using the tuning fork for Weber test, like we strike it, and then we put the base of it over the forehead, and you will ask him in which ear he feels the oscillation of the tuning fork, okay. So usually it should be normal bilaterally. If there is conductive deafness in one ear, he will be able to hear it through the bone better than the ear, okay. And if there is sensorineural deafness, so he will hear the other side, and he will not hear from that side. So this is the Weber test. Rini test, we strike it and we put on the mastoid process here, and we will ask him, tell me once there is no more vibration, and once he tell you now, then you put it like 1 centimeter away from his ear. If still he can feel it, okay, so there is no problem, okay. If he cannot feel it and he feels through the bone, so that means more like if he feeling with the other ear, that means there is conductive deafness here, okay. And if he is not able to hear in that side, so there is sensorineural as well. So this is for the Rini and Weber test for vestibulocochlear, and to be frank, don't expect that you are going to be tested for cranial nerve, eighth cranial nerve, which is vestibulocochlear. The remaining glossopharyngeal and vagus, you are not expected to examine in the exam because it's hazardous. You will check gag reflex, he may vomit, okay, and also you have to use like tongue reversal, and they ask him to say E to check the vocal cords. So usually you don't do, only if there is dysarthria or any problem, dysphonia or anything, you should comment that I would like to check, but better not to do as you are caring about the child and you don't want any risky procedure. So also you can ask him to swallow and see if there's no drooling or anything, so that indicates as well that he's having a good glossopharyngeal and vagus. So as we know that vagus is supplying the vocal cords through the recurrent laryngeal nerve, so if there is any dysphonia or hoarseness, that will give you a clue that maybe vagus is affected. And regarding glossopharyngeal, for drooling and for also gag reflex, as I mentioned. So the remaining 11th is the accessory nerve, and as we know, it's supplying trapezius and sternomastoid muscle. Okay, so sternomastoid muscle, when I ask him, okay, to move his neck against resistance here, so it's this lateral side, so he would be able to here against resistance, and here the same. Okay, so that if there's any weakness, that indicates accessory nerve injury. And trapezius, ask him to raise his shoulder against resistance. Okay, and finally hypoglossal nerve, ask him to protrude his tongue, so if it deviates to any side, so it deviates to the it's the reverse of the fascia, so fascia deviates to the healthy side, here it deviates to the diseased side. Okay, this is for glossopharyngeal, hypoglossal nerve. And finally, these are the summary of the cranial nerves. The most important thing is to be familiar with eye examination. The second important one is facial and trigeminal. Okay, all other remaining cranial nerves are not important, as I mentioned, eye examination is taking too much time, and you can also add to the neurology station if sometimes, as I mentioned, if you found any obvious squint or eye signs, you have to offer to do eye examination. Also, you can be asked for eye examination in case of thyroid exam. Don't expect him that he will do full eye examination, but he will ask you for eye movements and covering and uncover test. So that was our session here today about cranial nerves and what to do. Maybe if we practice more, and we can check also YouTube for how you can do it in a fluent way. It's easy actually, but needs more practice so as to apply in a very brief time without consuming the whole time. As I mentioned, some examiners will ask you to do added to a certain other task, like in thyroid. Okay, it's a good station, but he will ask you for an examination also in same for neurological exam. Thank you for your listening and attention, and I'm waiting for your questions and your feedbacks. Thank you and goodbye.